right? I need to remember that. There always has to be a quiz before your lab practical, otherwise you won't come. Okay, so last time what we talked about was the protective layer surrounding the brain, yeah? So we did the meninges, but we need to do them in a little bit more detail because there's more to learn about the meninges. So what we said last time was that there is a space around the spinal cord superficial to the Dura Mater. There's a space called the Epidural Space, right? And it's filled with loose connective tissue and fat. You guys remember that? But that is not the case around the brain. The brain doesn't have a space surrounding the Dura Mater. What it has is the Dura Mater, the superficial layer, is directly, it's stuck to the periosteum of the skull. So let me orient you to this figure so that you can see what you're seeing. Okay, so if we start from the cerebral cortex, the little sort of purple line around it would represent the Pia Mater, correct? And then this spider webby stuff would represent the arachnoid, and also within it the subarachnoid space, yeah? And then notice that you have two layers of Dura Mater. Do you see two layers? Yeah? This layer will stay with the brain, and then this layer will be fused with the periosteum of the skull. So you actually have a superficial layer, which is called the periosteal layer of the Dura Mater, and it holds the dura to the skull. So it's really positioning your brain within the cranial cavity. Does that make sense to you guys? So that's called the periosteal layer. And then this layer right here, this layer stays with the brain, and that one's called the meningeal layer of the Dura Mater. So what you have probably seen and thought of as the Dura Mater before is actually the meningeal layer. So let me show you this picture of this fresh brain. So here's a fresh brain, and what they've done is they've removed the calvaria, which is the top of the skull. And so when you remove the calvaria, the periosteal layer will come with it. So you're not seeing that layer because it goes with the skull. What you're seeing is the layer that stays with the brain, and this is called the meningeal layer of the Dura Mater. Okay, but importantly, there are, in a few places, there are blood vessels, really important blood vessels that go between the periosteal layer and the meningeal layer of the Dura Mater. So let me show you one here, and then I'll tell you what we're looking at. Do you see this big, wide blue space right there? What that is it's a big, wide, open blood vessel, and it's called collectively, there's a bunch of them running between the periosteal and the meningeal layer of the Dura Mater, and they are called Dural because they're between those two layers, Venous because they're veins, sinuses because they're wide open, right? Dural, does that make sense? Dural, venous, sinuses. You will learn them in lab. You'll learn them with the cardiovascular system chapters, but these are going to be really important because when we get through it today, you will see that they are the sites in which you dump old cerebrospinal fluid back into the bloodstream, the dural venous sinuses. So let me show you them collectively, realizing that you're not going to be responsible for naming them individually now. I just want to give you a big picture understanding of the blood supply being drained from the brain. So you see these right here, right? This one is one that runs right under the sagittal suture, and it's called the superior sagittal sinus, and that is the one that you're seeing right there, right? So if you do a coronal section right smack here, you're going to see this blood vessel right there, or that's it right there too, right? Superior sagittal sinus, go ahead.
Spaces or sinuses, is that where like brain tumors develop?
Not usually. You can have if you have you can have more likely a stroke in one of those or a blood vessel burst in one of those. But there's not a whole lot of active dividing tissues in there. But if you're thinking about like a subdural hematoma, it would be below the Dura Mater, just below that level. You can actually end up having high pressure in these, but they're really wide, so it's hard to get the pressure really high. So they're not as likely to be problematic. So I'm going to just give you a big picture intro to this, and you'll see it later. And I don't test you on blood flow yet. But basically what these are going to do is they are going to sort of collectively drain all the blood and cerebrospinal fluid from the brain. Okay, and they are going to come together. So you've got these, they're all coming together, and they're going to go up this way. And then they are actually going to dump into your internal jugular veins. Yeah? And the internal jugular veins are going to drain the vast majority of the blood from the brain back into the cardiovascular system. And so the direction that blood flow would be going through these is like back and down. make sense? So collectively, they're called the dural venous sinuses, and the only one that you'll really see in this set of notes is the superior sagittal sinus because it's in all the pictures that we're going to see. Does that make sense to you? Okay. The inner layer of the Dura Mater is called the meningeal layer, and you're seeing the meningeal layer here, and I'll show you a video of it in just a minute too. The meningeal layer forms the external covering of the brain, and when it is intact, you can't really see very much about the internal features of the brain, right? You will, week after next, after you do your lab practical, you will do a dissection of the sheep brain. If you get one of the good sheep brains, it will still have the Dura Mater on it, and you won't be able to see any of the structures until you remove the Dura Mater. So here's the Dura Mater. But it's really cool to see how it folds in and surrounds the brain because, this is what I forgot to tell the other class, but I'll go tell them next time. The meningeal layer of the Dura Mater doesn't just stay on the surface of the brain. So imagine you've got like an opaque sac, and by the way, it's made of dense irregular connective tissue. It's really strong in a bunch of different directions. So it's folding over there. But then it also folds into just the biggest fissures of the brain, like this longitudinal fissure. It folds in, like a little septum in there. Also folds into the division between the cerebrum and the cerebellum, right there. And it folds in between the two halves of the cerebellum. Okay, so let me show you those. Now these are hard to picture. We do have really good specimens to show them when you get to lab. So you will have seen them 2D and then you'll see them 3D. So let me show you what they're talking about. So here, what they did in this picture is they took out one of the cerebral hemispheres. And then do you see this opaque membrane right there? That is actually the meningeal layer of the Dura Mater folding into the longitudinal fissure. Yeah? And this is called, this big one, it's called a falx cerebri. Falx cerebri. It is a dural, they call them collectively the dural septa, and septum means partition. So they are the partitions made of Dura Mater, right? Okay, now this is the one that's really hard to picture because this one goes this direction, and it's really hard to picture in a 2D. So I'm going to tell you where it is. And then once you actually get into the cadavers, and you can look, a lot of our cadavers, at least one on each campus. I don't know if you've noticed this, but you can pull back the skin on the head and take off the calvaria, and then you can pull out one half of the cerebral hemispheres. And when you do that, you can see all of these. You can see them all intact. Okay? So make sure that when you get to those points and you're looking at the dural septa, week after next, you ask somebody to show that to you, right? Because seeing it 3D is totally different. So anyway, this one right here is the falx cerebri. This one right here, really hard to see in this picture. But what I want you to imagine is your cerebellum is right here and your cerebrum is right here. You have one that goes this direction and separates them. And that's called, where is it on here? The tentorium cerebelli. You can kind of see it right here. See it like, it looks like it's going up, but it's actually flat. Okay, it's going that direction. And then you've got one more that's kind of tiny, and that's this little guy right here that goes between the two cerebellar hemispheres. And that's called the falx cerebelli.
So this is all part of the meningeal layer, so it's all dense irregular connective tissue.
It is, yes. Okay, so the cool thing about that is if you happen to be lucky enough to get the sheep brain with one intact, be careful when you're pulling it off to see where it comes from, right? So you slice open the Dura Mater and then you start pulling, and you can see it actually pulling out of the longitudinal fissure and pulling out of the separation between the cerebrum and cerebellum and between the other halves. Then you'll get an appreciation for what it's actually doing. But it's one of those things that's damn near impossible to imagine when you're talking about it 2D. You really have to get 3D in order to see it. So we have several different ways for you guys to look at it, both in sheep brains and also in human brains. We have a bunch of human brains in jars. We have some that are still in the cadavers. We have like some mid-sagittal sectioned heads as well, so that you can see these things with those kinds of things. Okay. The falx cerebri also is interesting because the falx cerebri helps hold your brain in position because the falx cerebri attaches to the cristagalli. And so when I remove a brain, right, and take, you really can't remove it without removing the meningeal layer of the Dura Mater. It has to come out with it. I actually have to cut it off of the cristagalli of the what bone? Of the head bone. exactly. Have to cut it off. So if I'm trying to pull it out, I can't get it out unless I cut it off there, and then I have to go down and snip the spinal cord as well to get it to come out. Does that make sense? Okay. All right. I love doing brain dissections. They're my very, very favorite. It's fascinating to get them out of there. Okay, so we already talked about the subdural. There isn't really much in the subdural space. When we move down to the arachnoid, let's just talk about it in a little bit more detail. So the arachnoid is here, of course. And what the arachnoid really does is it has a bunch of little fibers, mostly collagen, but a few elastic fibers, that really attach the Pia Mater to the underside of the meningeal layer of the Dura Mater, right? So it's really spider webby. And where is the subarachnoid space? Like I mentioned to you guys last time, it's really not subarachnoid, it's really intra-arachnoid, right? But they call it the subarachnoid space, just so you know. So you got a whole bunch of room for fluid in here, and this will be full of cerebrospinal fluid. And then you also have room for blood vessels to be running, right? These are not as big and wide as these that are in the dura, but the blood vessels are going to be running here. Is that okay? Okay.
So I'm a little confused, I guess, where the subdural space is to the arachnoid.
It's right
So
here.
just that little space.
This little, there's hardly anything in it except just a little bit of interstitial fluid. It's not like functionally important unless, of course, you get a subdural hematoma and like a blood vessel. There are blood vessels in there and they can bust, right?
Okay. So
But
arachnoid villi is in
that makes sense. So periosteal layer
Yeah.
and meningeal layer of the Dura Mater subdural space. Both arachnoid and subarachnoid space
okay.
simultaneously, right? So, and then this is the Pia Mater that you run into. Does that make sense? Okay. So, all right. So let's talk a little bit more about the arachnoid and the subarachnoid space. So these little guys right here, do you see where at certain spaces the arachnoid reaches up into these blood vessels? This is going to be really important because we're going to talk about cerebrospinal fluid circulation today. And you are continually making fresh cerebrospinal fluid and you make it inside your brain. We'll talk about that in just a second. So you have to have a continuous turnover of the old stuff. And so what these are is kind of like one-way valves. This is really wide and venous, so it's relatively low pressure. You guys with me? If you're a wide vessel, you're going to be relatively low pressure, and also venous is lower than arterial. You okay? Okay. This has a continual production of cerebrospinal fluid, so it's going to be comparatively higher pressure. With that arrangement, what's going to continue to happen is you are going to push fluid from here to here all the time. And I didn't know until the last class, but one of my students looked it up. You have about a turnover of 700 milliliters of cerebrospinal fluid every day, which is pretty fascinating because you usually only have 500 inside your brain at any given time. So you turn over the entire volume plus a little bit every single day. Go ahead.
I don't have anything to, I don't remember who told it to me, but they were saying that when you sleep, then your body does like a rinse of cerebrospinal fluid.
Oh, I don't know that. I wonder if that's true.
I can't verify it, but hearsay maybe.
It's pretty interesting. I wonder if it's true.
Yeah,
I can look it up. If you find out, will you tell me? And if I find out, I'll tell you. Okay. Somebody told him that you do like a rinse of cerebrospinal fluid when you're sleeping. Is it sleep? Sleep related? Oh, interesting. Do you work at a traumatic brain injury place? Yeah. So he'll probably have some really like
on that.
on cerebrospinal fluid.
On that. Yeah.
Oh, interesting. Thank you. Send it to me. Awesome. Okay, so turnover of cerebrospinal fluid. We will get back to that because we're going to talk about cerebrospinal fluid circulation in just a little bit. Okay, so the space that I say it's deep to the arachnoid mater, but it's really within. This is going to have a continuous flow of cerebrospinal fluid. We'll talk about that just a little bit later. In addition, there are always a bunch of blood vessels in here. Okay, and so if you look at this figure, this is probably an oversimplification, but you're not seeing the dura, right? It's gone, right? So you're not going to see like the superior sagittal sinus or anything that will come off with the dura. What you are probably seeing is, in all likelihood, some of the bigger vessels are in the subarachnoid space and some of the smaller ones are under the pia, right? Does that make sense? There's no hard and fast rule about how big or small you have to be in one place, but generally speaking, the larger arterioles are in the subarachnoid space, and then the smaller ones, as they get even smaller than that, are going to be in the Pia Mater. Okay, so the Pia Mater, when you are looking at the surface of a fresh brain, it looks shiny. Kind of like when you're looking at your abdominal organs, the serous membranes make them look shiny. This isn't a serous membrane because the Pia Mater doesn't actually produce fluid, but you are actually seeing it closely stuck to the surface. So right here, mostly what you're seeing is Pia, but whenever it's kind of hazy, you're usually seeing a little bit of arachnoid that's stuck to it as well. And I'll show you guys a fresh brain dissection before we leave today, so you'll get to see all of these kinds of things. Is that okay? Everybody good? Okay. Okay, so now let's talk about cerebrospinal fluid. Cerebrospinal fluid, sites of production, and then circulation and how you get rid of it. We'll go through all of it. So cerebrospinal fluid, I'll remind you what we told you before. So remember this figure that we've looked at multiple times. So what we're trying to see right here is the open spaces in the brain. So you're doing that little chunk. The cells that make cerebrospinal fluids are the cells that line the open spaces of the brain. So let me show you. You may or may not be fully aware that your brain and your spinal cord, your entire central nervous system, is hollow. It actually starts out flat and then will fold and leave spaces within during the process of development. The spaces within the brain are called ventricles collectively, okay? And the space within the spinal cord is called the central canal of the spinal cord. It's much smaller. Okay, so the ventricles all have names. These two, so this kind of looks like, I don't know, like an angry chicken or like a really organic SS Enterprise. I don't know what it looks like on the inside. So these two right here are 1 and 2, but nobody ever remembers which one's 1 and which one's 2. So they're called the lateral ventricles, usually right lateral and left lateral ventricles, but they are ventricles 1 and 2 because this one's 3. The chicken head is 3, yeah? And then from here, the chicken neck on the way down, that's not a ventricle, it's called an aqueduct. And there's 2 names for it. The name that they used to use was the cerebral aqueduct, which is way easier to spell. Now they have changed the name to the mesencephalic aqueduct, which won't make a damn bit of sense to you until we realize later that this is not actually running through the cerebrum, it's running through the mesencephalon. So that's why they changed it. I don't care if you call it cerebral. It's fine. It's still called cerebral in a bunch of different textbooks. So 1, 2, 3, aqueduct, 4. Yeah? And the 4 is between the brainstem and the cerebellum. Does that make sense? Okay, so let's look at how inside those things you produce cerebrospinal fluid. Unfortunately, the pictures that they have in your textbook I really hate, so I have to like just over-describe them to make sense to you. Okay, so on the wall of each of the 4 ventricles, you are going to produce cerebrospinal fluid. And the way you're going to do it is these cells are going to back up to a wad of capillaries. They aren't showing very many here, but there's a whole bunch of capillaries. And they're sort of going to wrap their little extensions around this wad of capillaries. And when you have the ependymal cells plus the capillaries, it makes a little snotty little booger-looking thing on the wall of the ventricle. I'll show you. And that is the site of cerebrospinal fluid circulation. Do you see that? Okay, so what this is, I think, because they didn't label it well, and this is part of the reason that I hate this figure, I think that this is a section through, like back here, where the ventricles are small. But it doesn't say. So it's at least the lateral ventricles, otherwise they wouldn't be paired. Does that make sense? Okay, so this little thing that has blood vessels and ependymal cells on it, all in a wad, is called a choroid plexus, and the choroid plexus is the site of cerebrospinal fluid production. Here's what the ependymal cells do. They pull all of the best stuff from the bloodstream. High concentrations of glucose, high concentrations of calcium and chloride and sodium and potassium and vitamins that your brain likes. And then they pull it from the blood plasma and then they dump it into the ventricles of the brain as cerebrospinal fluid. Yeah? Really juicy, nutritious stuff that will end up bathing the inside of the brain in the ventricles and the outside of the brain in the subarachnoid space. Does that make sense? Okay. Blood-brain barrier is different. We'll talk about that too. Okay, so this is what I would recommend that you do so that you can get, I mean, you don't have to do this. It's not actually in the dissection. When you do sheep brain dissection, week after the practical. After you've done the dissection that it tells you to do, see if you can carefully open up any of the ventricles and see a little booger on the wall, and that will be a choroid plexus, right? And you know that once you see something physically 3D, you are unlikely to forget it in the future, right? That is why, although there's a huge push nationwide, just so you know, to make, to say that now that we have all of this technology, we should no longer be doing cadaver dissections, and we should never ever be using animal organs.
What?
Yeah, because there's so much digital technology. They're like, you can see anything. But I have done it both ways. And do you guys think it's the same?
I can't learn that way.
I don't think it's the same. In addition, I can't really see any particular ethical problems with doing cadaver dissections in the way that we are required to do it, which is that I have to donate my body before I die for this particular purpose. But definitely they're trying to take away all the animal organs. Yeah, I used to get to do live animal stuff in physiology lab too when I took phys lab. We had frogs that were alive when we were doing stuff to them. And I promise that I understand physiology really well. So anyway, so I would like it if you guys look for those. I don't always find them because the sheep brain's really small anyway, but I usually find them in like 3 brains per lab. So it's worth looking for. Okay, so those are your ependymal cells in the choroid plexus, and those secrete cerebrospinal fluid. And then what is the fate of cerebrospinal fluid? Well, it's got a couple of different fates, and we'll look at it this way, and then we'll look at it a different way. So you make cerebrospinal fluid in all ventricles, 1, 2, 3, and 4. There's a little thing on the wall. And then the way that it has to travel is the stuff that's made in 1, 2 can't get out unless it goes through 3. Yeah? And the stuff that is 1, 2, and 3 can't get out unless it goes through the aqueduct, right? And then it all collects in 4 ultimately. And then you've got a couple of different fates. Once you're in 4, you can either go down the central canal of the spinal cord, or you can go out these holes. And the holes are called apertures. And if you do photography, you know what an aperture is, right? Okay. So you've got 2 lateral apertures and 1 median aperture. And what they do is they reach from the inside of the brain into the subarachnoid space. And that's how you get the fluid from the inside where it's made to the outside where it also circulates. That makes sense? And it circulates in the subarachnoid space, not just in the brain, but also around the spinal cord, all the way. Does that make sense? Okay, so let's look at it in this figure then. This figure is supposed to show you cerebrospinal fluid circulation. Okay, so when you have a model, the choroid plexus usually looks like that, right? It's some kind of little pink or blue or yellow booger on the wall. So this one is showing you there's a lateral ventricle behind there. There's actually a little window protecting it. So 1 and 2, 2's over here, 3, making cerebrospinal fluid. It all has to go down the aqueduct, yeah? And then go into 4, where you pick up some more, because there's another choroid plexus, another booger. You're going to call them boogers from now on, aren't you? Okay, brain boogers. And then this one, since it's a mid-sagittal section, you're only seeing the median apertures. You're not seeing the 2 lateral apertures. And they're going to reach into the subarachnoid space. And then the fluid circulates all the way around the subarachnoid space, around the brain and the spinal cord. Okay? Then, how do you get rid of it? Well, you already know. How do you get rid of it? What? The arachnoid villi. So the arachnoid villi are going to lead up into the dural venous sinuses, and they are going to continually get rid of the old stuff as you're making new stuff from the inside. Yeah? And you apparently have a turnover of about 700 mils per day, even though you usually only have 500 mils in your brain and spinal cord at any given time.
So they absorb. So they like absorb the.
It's not absorption.
Or do they push it out?
It's just a pressure difference primarily, that this is higher pressure than that. And so it pushes it out because you have continual production in a really low pressure vein.
Where does it go?
Into bloodstream. Well, it started out as blood plasma and it just ended up as blood
keeps being
plasma.
recycled.
Yeah, yeah, over and over again. And so why do you need constant new stuff? Well, because remember you're bathing the inside and the outside of your central nervous system with oxygen and glucose and ions. But then, of course, you're going to use up the oxygen and glucose and ions, and you're going to generate waste products, yes, and carbon dioxide. And so you have turnover, so it's always being bathed with the freshest, juiciest stuff. Go ahead.
So, are the arachnoid villi, is it a selective membrane, or is it just like?
It's not.
One way goes, like everything, even if there's still good stuff in there.
The whole fluid moves. It's not selecting by actual component in the fluid. The entire fluid moves into there. Okay, so, and the arachnoid villi, remember if you look at them up close, they look like that, right? Okay, go ahead.
So would it speed up? So if you were generating more waste products, like if you were really, really active, then would it speed up because of the pressure difference in your?
I don't know the answers to that. That's a good question. Here's what I know that is related to that. What I know that is related to that is that there is no negative feedback inhibition mechanism that's very dependable for stopping the production of cerebrospinal fluid. It's not very tightly controlled. It has a continuous production mechanism, which is kind of unusual, right? Because if I get up to 5.5 liters of blood, I will say I don't need any more blood, right? But cerebrospinal fluid has continuous production of cerebrospinal fluid, and it doesn't seem to have a negative feedback inhibition mechanism. Doesn't really stop making it, and that's why you can get hydrocephalus, and we'll talk about that. What?
It'll probably just take the rest of your body first, right?
Yeah, I don't
Like,
know.
keep
I've never
your
looked
brain.
into the mechanism that happens if your brain is more active. Your brain gets different blood flow when it's more active, but I don't know if it has a change in CSF flow.
Or,
I can look that up and see. Go ahead.
I mean, for example, if you were deficient in certain nutrients or weren't eating, like if you weren't eating and you were starving, right? Your brain would probably continue to try to like take
The blood-brain barrier tries to take care of that, and it has a lot more control than cerebrospinal fluid.
Oh, really?
Yeah, and we'll talk about that in just a second with the blood-brain barrier. So this one is different juice than the blood. This one is bathing just the ventricles and the outside of the brain, right? And then we'll talk about the blood-brain barrier in just a second. So at any given moment, you usually only have about a half cup or 500 mils of CSF. If you get more than that, you're going to have the worst headache in your life. If you get less than that, you're going to have the worst headache in your life. And headache is the least of your problems, honestly. If you start building up too much cerebrospinal fluid, they can, for instance, have to take off a chunk of your skull to allow for the excess. It contains all of the good stuff, and one of the other advantages, in addition to sort of bathing you with this rich soup, is that it also provides a mechanical protection from the brain. So we've all been hit in the head before, but most of us haven't had concussions. And in part, that's because our Dura Mater is holding it in position, and also we were sort of sloshing through the subarachnoid space and the cerebrospinal fluid before you smash into the side of your skull. And so, of course, concussions do happen, and apparently they happen far more frequently than we thought, right? If you listen to the information about football players and soccer players, and don't let your kids head the soccer ball. Don't let them do it. I know. You could have been 5 IQ points smarter, but you can't remember. Where are my keys? So it cushions the brains from jolts, and it's apparently relatively effective, although not as effective as we expect. So you can either do the circulation in the way that we just did it, like this, or if you are a flowchart person, and I am a flowchart person, I'm not a very visual person, you can write it out like this, and then I'll add just a little bit more detail. So what cells make cerebrospinal fluid? Ependymal cells. And the ependymal cells are in a little booger called a what? Choroid plexus, exactly. So the first place that you can start the story is the ependymal cells in the choroid plexus of the lateral ventricles. Yeah, 1 and 2. And then from there you will go pick up some more made by the ependymal cells in the choroid plexus of the third ventricle. Yeah? And then you have to go through whatever you want to call the aqueduct. And then you pick up more made by the ependymal cells in the choroid plexus of the fourth ventricle. And then there's a couple of possible fates. You can go down the central canal of the spinal cord. Or you can go, and this, by the way, if you go into the central canal, you're not going into the subarachnoid space. It's just staying inside the tissue. And it gets pushed back up, too. And then you can go out the median and lateral apertures into the subarachnoid space. That's how you get into the subarachnoid space. And then out the arachnoid villi into one of the dural venous sinuses. This is the only one you've learned by name so far, the superior sagittal sinus. But they figured out recently that there is also another mechanism of getting rid of cerebrospinal fluid, and that is that apparently it leaks down your cranial and spinal nerves. You lose a little bit of it down your cranial and spinal nerves. And they didn't actually know that until about 10 years ago. They thought it was kind of a closed system. Yeah, so apparently, I don't know how much of it leaks down your cerebrospinal fluid. Okay, so now I want you to look at this anatomy, and I want you to tell me if I got a blockage, what would be the most severe place that you could get a blockage? Do you imagine?
Lateral ventricles.
Oh. So remember, it's made here, has to go through here, here, come out here. Any idea?
Where it comes out.
Where it comes out, there's 3 holes though. If you got a blockage in one, you'd still have 2 more. The villi, there's a bunch of them.
Yeah.
Cerebral aqueduct.
Yes. So this one is a big one. If you have a problem, a blockage in the cerebral aqueduct, then what you'd have is a buildup of all of the stuff from 1, 2, and 3 that couldn't get out. And that's a big, big deal. It can happen developmentally, embryonically, and when it occurs, we will go from, just look at this size and then I'll show you another one. Okay, so this coronal section right here shows you the approximate size of those lateral ventricles, and it changes as you change position. But let's assume that that's the starting point, and then show you that this is a post-mortem of someone who had a blockage, right? And these are the lateral ventricles, and these are also the little tails of the lateral ventricles. Do you see how big those are? Right? This is the 3rd ventricle. This is post-mortem of an infant brain with hydrocephalus. And hydrocephalus, generally what occurs because of something developmental, you have a blockage of the drainage of cerebrospinal fluid, but you don't stop the production of cerebrospinal fluid. And so what happens is this developing brain, you put pressure on the developing brain against the skull during development. And since the skull has a tremendous amount of plasticity, what that is going to occur, if a live birth occurs, is that you will get a massive, massive increase in the size of the head. This looks like the fluid would be between the brain and the skull, but it's not. It's actually within the brain. And of course, you get one shot at putting your nervous system together, right? And if you have this pressure on your developing brain, it is going to damn near invariably, especially at this level, cause a problem with the development of the cerebrum at the very least. And we will figure out that your cerebral cortex, the most superficial portion, is the portion that has the most unique to human characteristics, so personality, intellect, and those kinds of things. That's the type of functionality that you're probably going to lose. This infant has pretty severe hydrocephalus, and I, of course, am not a diagnostician, but I would imagine that there's a severe, severe mental impairment to the point that this baby might not live. And if the baby lives, there will be, I don't know, you might expect a possibility of institutionalization for. So this is hydrocephalus. A lot of times the question that people ask is, so if this is diagnosed in utero, and sometimes it is diagnosed in utero. For those of us who have been pregnant, every time you go in, past a certain number of weeks, they measure the head, right? They don't just measure the head, they measure the head and they measure a femur and they measure a couple of other bones because they're looking at the relative proportions of the bones. Because sometimes you might just have an enormous baby. Like my 17-year-old, he's 6'6" now, and he was over 10 pounds, but he's my step kid, so somebody else's baby. So. I got him when he was 3 after he already came out. I'm like, yeah. So it's the relative proportions. So what would you do, if you figured out that your baby had hydrocephalus? Well, immediately what comes to mind is we got to go fix it. The problem is, after you can measure it, the damage to the central nervous system has already been done. So all of the heroic measures that you wanted to do and go in and put in a shunt, for instance, to get it out of there, those are not going to undo the damage that was done with the developing pressure during the first part. They could reduce the future damage, but you know that in utero surgeries are outrageously expensive and also very, very risky and have pretty low efficacy. So rarely do they actually try to intervene in these kinds of situations. So just so you know. So why does this occur? Well, sometimes chance is a jerk. And also, there are some things that you can do to prevent it, but is it generally going to be related to the mom eating or not eating something, right? Smoking crack or not, with a few exceptions. is not generally related to those things. It's just a chance occurrence. Although, this is what's considered one of the neural tube defects. And neural tube is like when your nervous system starts out flat and it closes. And when it closes, you should have proper development from the anterior to the posterior end. And we do know one good predictor that will prevent neural tube defects. And that is that any woman who is pregnant should have adequate levels of folate or folic acid. Folate or folic acid. There was a big education campaign 20 or 30 years ago. They figured out that you could reduce the probability of neural tube defects, including hydrocephalus and spina bifida, by making sure that women who are pregnant have adequate levels of folic acid. But here's the important part, and this is the part that all of us who are still in reproductive age need to know. You need folic acid during your entire pregnancy, not just when you know you're pregnant. You need it during the first 2 weeks of pregnancy. So this is important for women and their partners, assuming that their partner is heterosexual. They need to know that if you could possibly get pregnant and would not terminate a pregnancy, you should probably make sure that you're getting adequate levels of folic acid in your diet. And folic acid, you can get it in any multivitamin for women, for sure. But also you can just drink some orange juice and eat some leafy green stuff every day. You're probably going to be totally cool on folic acid. If you are, however, in college and surviving on ramen and $5 Little Caesars pizza, you might want to pop a vitamin, right? And everybody's like, oh, I wouldn't get pregnant. Just so you know, half of pregnancies are accidents, right? Okay, all of us were virgins once, every single person, right? Most of it is not planned. If you get a blockage as an adult, and this can occur with a brain injury, you can have swelling that causes a blockage, then your brain development has already occurred. So what do you do if you get in a blockage as an adult, or even as a fully developed kid? They usually just put in a shunt. They stuff it up past whatever the blockage was, and maybe they do it differently now, and maybe you know. The way that I know about is that they usually run it under the skin and dump it either into your subclavian vein or all the way down into your peritoneal cavity. Do you know which one they do?
I think at my hospital we do a lot of shunts.
Oh, yeah. What do you do?
I think that's how they do it because we do a lot. Because I pick up a lot of kids on the trauma unit or the neuro trauma unit. We do a lot of.
Do you know where they usually dump
I
it?
think they do it right there.
In the subclavian vein?
Yeah. We do a lot of revisions of shunts.
Oh, yeah. And so as the kid grows, if it's a child, they're going to need to change the shunt because you're going to get taller, right? Yeah, they need to change them. And usually they're fine with changing the shunt. If you get it in there and it's safe the first time, then it's basically just kind of a rigid tube that will dump into the subclavian vein, and they just like sew it in there so that it dumps. And it doesn't have much problem because, of course, the fluid is being generated at relatively high pressure and it just goes straight in there. Which is kind of interesting. So anyway, that's cerebrospinal fluid circulation. I will ask you, by the way, you won't have a test next week, but it will be the week after your practicals, and you will have to do cerebrospinal fluid circulation. Absolutely. Okay? All right. Last line of protection. So we went through the lines of protection. They started with bone. They went through the meninges. Then we had cerebrospinal fluid. And the last line of protection is what's called the blood-brain barrier. The blood-brain barrier is a little difficult to understand because it's not just an anatomical barrier, it's also a physiological barrier. So what I want you to remember is, let's go back to this figure for just a second. Okay, so the blood-brain barrier, I want you to imagine your brain getting its blood flow. And so the blood flow of the brain goes primarily, almost exclusively, through 4 arteries. The 2 internal carotid arteries, which go through the carotid canals, right? And then the 2 vertebral arteries, which go up the transverse foramina of the cervical vertebra, and then they fold anterior to the medulla oblongata, and they go up the foramen magnum. So it's all like coming up the bottom side into the brain. So, but then you need to get blood supply to every single neuron. You need to get it within a millimeter of every single neuron. So what's going to happen is those 4 arteries will split into some smaller arteries and some smaller arteries, and then some arterioles until you're actually delivering blood primarily from the outside in to the brain. And then the capillaries are going to be everywhere in the brain. It's highly, highly vascular tissue. It only accounts for 2% of your total body weight, but it actually consumes 20% of your oxygen and your glucose. It's a hog. And it doesn't just consume it when you're awake, it has almost the same metabolic rate when you're asleep. And the other thing is that the brain needs super good blood supply because it has almost zero capacity for anaerobic cellular respiration. What does that mean? Without oxygen generating ATP. And even though it's a glucose hog, and it prefers glucose above all other nutrients to the point that it gets really pissed off when you try to switch it. It will switch, but it'll be mad. And it stores no glucose, so it doesn't actually store its own glycogen. If your brain at normal body temperatures is without arterial blood supply for 1 to 2 minutes, the tissue will start to die. So it's intolerant of what we call ischemia. And I'll show you these arteries later. Then once we get into the capillaries of the brain, I want to talk about how your capillaries protect your brain from the funky stuff that you take in. So this capillary right here, okay, you got a lot more than this, it's just showing you one of them. So the blood-brain barrier is an anatomical entity, but it's also a physiological entity. The anatomical nature of the entity is I want you guys to be the simple squamous epithelium making up a blood capillary in the brain, okay? And then what I am is something funky that I took in, right? I took in some kind of pathogen or some kind of toxin. And you do. The stuff that you eat is not sterile. It has pathogens in it. You take in toxins sometimes because they're yummy and sometimes you're bored on a Saturday night. And then what happens is the blood-brain barrier has the most tight of tight junctions. So I can't get through without asking permission. And they are called continuous, complete tight junctions. Pretty much I'm not messing around tight junctions, right? So that's the anatomical barrier. That means that unless I have permission, I can't get through. And then the physiological barrier is that this astrocyte right here snuggles up and wraps around the capillary like this to control permeability. And so the astrocyte can change permeability based on what the brain needs. If you guys are producing a whole bunch of waste products, the astrocyte will increase waste transport into the bloodstream. If you are low on nutrients, it will increase glucose transport into the brain. If you have too much glucose, like I ate a pie, right? I ate a whole damn pie because it was a good pie. You slow down glucose transport, right? And so her question was, who asked something? I can't remember who asked something about when you're starving. So if you haven't eaten anything, your brain doesn't go, it was a nice run, I'm out. What it will do is it will tell every other organ in the body, no glucose for you. And then it will start eating your muscles and pumping the glucose into your brain. So the blood-brain barrier protects from toxins and pathogens and sort of buffers the variability of the stuff that's going through your bloodstream so that your brain gets almost constant nutrient levels despite what you're doing to it. Does that make conceptual sense? Okay, so what about damaging your brain? What about that kind of stuff? What can get through? And then I'll show you guys a video of a fresh brain. So some things you can't control whether they get into your brain or not. Anything lipid soluble does anything it damn well pleases anywhere in the body. Sometimes it's good, like oxygen is lipid soluble, so it diffuses straight into the body. Sometimes it's got an asterisk, it might be good or bad. Alcohol is lipid soluble. So if I haven't eaten anything and I take a sip of wine, how long will it be until I feel it? 30 seconds, maybe? Right? Okay. Anesthetics are lipid soluble, but it doesn't really matter because you don't really have any sensation in your brain anyway. Other substances don't pass easily. Antibiotics, very hard to get into the brain. There's no transport mechanism for them, and the astrocyte says no way. Sometimes we know what needs to go into the brain, but we can't get it there. Parkinson's is where a part of the brain that needs dopamine doesn't produce it adequately. We know how to make dopamine in the lab. We know how to, we know where it needs to go, but we can't get it through because of the blood-brain barrier. The best that we can do is give the lipid-soluble precursor to dopamine called L-DOPA. And as long as you still have some of the cells in that area that can do the transformation, you'll get a relief from Parkinson's symptoms. So it works in the first stages, but not in the later stages of Parkinson's. So now, inflammation, the only good thing about brain inflammation is that it temporarily destroys the blood-brain barrier. Just temporarily. They're epithelial cells, they will heal. So if somebody has a head injury, in addition to trying to take care of the inflammation, which can cause brain damage in and of itself, And they usually do that with really aggressive measures like using prednisone and other steroids, and then taking off a chunk of your skull if necessary. But they usually also, unless this has changed, and maybe he knows, they give antibiotics because that's the time that you can get antibiotics in, and that's the time that an opportunistic infection would make it into your brain. We don't know that you have a brain infection, but we're going to take care of the possibility that you might get one during this particular time. That make sense? Okay, so before we actually get into brain stuff, I'll use the last few minutes to show you guys what a fresh brain looks like. Because the brains that you are going to see, whether it's sheep brains or human brains, we shoot them up with straight formalin. Because they're so fatty and they disintegrate so very quickly that you won't ever get to see the actual texture of a fresh brain. So I thought I'd show you one. This one's from the University of Utah's Neurobiology and Anatomy Department, and her name is Suzanne Stensis. She's going to show you the texture of a real fresh brain. She's also got one for the spinal cord too. Oh, you seen it?
The brain, students think that the brain is sort of the consistency of a rubber ball, and that's because in the laboratories and teaching specimens we have formalin-fixed brains. However, if you're a trauma surgeon or a neurosurgeon, you realize that the brain is really very, very soft and much more vulnerable than the impression you get looking at the fixed brain. So I would like to show you a 1,400 gram brain that has just been removed from an autopsy, and we are fortunate enough to be able to show you what a normal, unfixed, recently deceased patient's brain would look like. This is the ventral surface of the brain, and what you see are the peel vessels, this nice blush with the clear leptomeninges and the vessels running in between the arachnoid and the pia. The cerebrospinal fluid has leaked out through the cisterns, and so the subarachnoid space is no longer visible unless I move the brain, but it's very, very soft. Notice, it's totally squishy. It's the consistency, it's much softer than most of the meat you would see in a market. So if I were to pinch this in either way, I could easily damage this with my thumb. In fact, neurosurgeons, when they are doing surgery, often just evacuate with a vacuum or suck out parts of the brain.
So interestingly, you don't actually even have to use a knife. They just use little suction and you can just like suck something out. It's like a bag of pudding, right?
This string here has been placed around the basilar artery so it can be suspended in a bucket of formaldehyde in order to denature the protein and harden it. If we didn't, it would sit on the bottom of the bucket and the brain would become deformed, as you would see here, so that it would be compressed in this direction just from the weight of the brain. So that points out one of the purposes of the cerebrospinal fluid is to float the brain inside the calvarium and act as a cushion. The cerebellum is easily seen, the medulla, the pons. Here you can see the arachnoid spanning across the space here at the base of the brain. The optic nerves are very obvious, as are the olfactory nerves. Here are our temporal lobes, and here is the uncus on either side. The uncus, remember, is the most mesial part of the temporal lobe. The tentorium that fit in here has been removed, but we can see a slight groove right along here where the tentorium sat. So there is no evidence in this brain of any of the temporal lobe herniating medially over the edge of the tentorium. It's a beautiful specimen. Unfortunately, this cancer patient died of complications secondary to a cell transplant. Here you can see how soft and pliable the dura is, and we can look down between the hemispheres and see the corpus callosum. I can also see a bit of the anterior cerebral artery coming over the surface. So this is the interhemispheric fissure. And if I turn the brain around and we look at the occipital lobe, we can see the top of the cerebellum. And here there is a very small amount of blood that was actually seen on MRI that the patient had before death. If I let the cerebellum hang down a little bit, you can see the superior surface of the cerebellum. Turn it back around. So our very delicate and vulnerable brain, with its two vertebral arteries on the medulla, its basilar artery on the pons, it's branching to the posterior cerebral artery right here where you have the cerebral peduncle, and here we have the space here is the interpeduncular cistern, and we can see the two mammillary bodies. The pituitary gland stayed within the body, and here you can see the base of the brain with the optic nerve, the chiasm, and the tract.
Okay, so she does the all the way through, and then she also does one for the spinal cord, so you can see the actual textures. It's pretty fun.